presentations. And thank you so much, Charles, for the invitation. So what I'm going to talk about today, as Charles mentioned, was about really the journey that I've taken with respect to looking at metabolic imaging for brain tumors. And so what I'm going to talk about a little bit is, I don't have any disclosures, really talking about the challenges with standard anatomic imaging for brain tumors. I think you may have heard some of this through Ben's talk as well. Look at the differences in metabolism that we can actually leverage in terms of imaging, and review some of the work that we're doing through NIH-funded grants, looking at glioblastoma, IDH mutant glioma, and more recently with metabolic imaging. So some of what I'm going to talk about is really about the efforts that we have that are ongoing with respect to our research efforts in the team. So when we think about the roles of imaging in brain tumor management, I think we can range it from diagnosis. So in some cases, it's actually a diagnostic finding. We don't often diagnose tectogliomas by going in and biopsying these. We can often see those as a non-enhancing lesion causing hydrocephalus, and that is pretty diagnostic here. We use it in some examples of CSF spreading tumors for staging. So for example, for medulloblastoma, we look at the brain and spine because we're interested to see whether this is a localized disease or whether there's evidence of dissemination. Probably for a surgical audience, how we use imaging is critical for eloquent regions of the brain and using this directly to help with surgical management. And probably what we're all familiar with is how do we assess the response to treatments for the various modalities that we have, whether it's surgery, for example, here, but any sort of response to therapies, especially for experimental treatments. There are many challenges in imaging glioma. This is just an example of a glioblastoma patient, but you can see that there are many heterogeneous areas within the tumor. These tumors are very infiltrative. They're spatially heterogeneous. So what do you define as the margin of the tumor here if you're going to measure this? And what do you do with a cystic component of it and essentially necrotic areas? So imaging is very good at showing us the anatomic location and the relationship to normal structures. But in terms of interpreting what is truly tumor burden, especially when we have things like edema, can be very challenging for an infiltrative tumor. The other is the large variability in the appearance on MRI. So here are examples of 4 different patients with tumors who are oligo or astrotypes, grade 3s and also grade 4. But you can see there's heterogeneity across the tumors in terms of the appearance of enhancement, where there's some focal enhancement. And even as we know now for grade 4 tumors in glioblastoma, there can be non-enhancing glioblastoma where they're molecularly defined as opposed to the classic vascular proliferation and central necrosis. Probably the biggest challenge I think we all face in patient management is what do we see after treatment? And these are 2 examples of patients who've had surgery, radiation, chemotherapy, and developed this enhancing mass. And it's really difficult on standard MRI to really differentiate what is true progression of disease as opposed to pseudoprogression. So just because you see a contrast enhancing mass, that can be very challenging. And probably what really led us to being challenged is the impact of anti-angiogenic drugs such as bevacizumab, where we see this dramatic decrease in contrast enhancement 24 hours after administration, which is really not compatible with what we consider a cytotoxic effect. This is just a reconstitution of the blood-brain barrier. The other challenge is seeing worsening flare despite improvement of contrast enhancement. And so what are we really seeing when we look at these scans post these types of treatments? And probably even with surgically based studies where we try to deliver drugs directly into the brain, that is also associated with potential difficulty in assessing pseudo progression versus true progression of disease. And these are just some examples of some of the work that was done very early on, looking at convection-enhanced delivery and direct intracerebral delivery of drugs, where we can recognize that there are specific imaging and catheter characteristics that we can see as a result of this intervention. So early on, back in early 2000s, the foundation of the imaging research goals for our team was really to see if we can use non-invasive imaging as a biomarker of biological behavior of subgroups of brain tumors and to detect early recurrence, to facilitate robust evaluation of new treatment strategies, and how do we make sure to validate these and translate this to clinical practice. So that's been most of the work that we've done over the last 20 years or so. This takes a huge team. Really, one of the great things at UCSF, and I think at most of our brain tumor centers across the nation, is this amazing collaborative spirit that we have. So this is our imaging science collaborators that I've worked with over the years, and the key brain tumor center collaborators, including our clinicians, such as Dr. Berger from the surgical side and Dr. David Raleigh from the radiation oncology side. So at first, let's talk about some of the other imaging techniques in glioma besides the standard MRI with contrast enhancement. We use the apparent diffusion coefficient, or ADC maps, to look at the architecture of the tissue and the cellularity. And this is something that we can use in conjunction with perfusion metrics. So the idea is often when you have more perfusion within a tumor, for example, this is the example of two non-enhancing tumors, one with very low perfusion and one with high perfusion. And this is sort of portends a higher grade of tumor compared to the lower grade tumors, which don't have a lot of vascularity. But I want to talk a little bit more about the focus of our group, which is looking at metabolic imaging, and specifically magnetic resonance spectroscopy. And this is to give us an information about the metabolites that are present within the tissue, specifically within normal cells, a normal brain. We'd expect to see some choline, creatine, and a high amount of N-acetyl aspartate, which is reflective of neuronal components. And so by doing this static or steady state acquired images of the brain and tumor, we can try to characterize differences in this, what we call this metabolic fingerprint that exists within normal tissue versus tumor. And this is something that we've been able to demonstrate in terms of the amount of choline relative to NAA, called the choline NAA index, or CNI, where we can see that a tumor pattern characteristically has this very, very high choline. You get loss of NAA because you've replaced the neuronal cells with tumor cells. And we can also look at lactate and lipid, because that's usually consistent with anaerobic metabolism within the tumor. And you can see these types of chemical peaks within the tissue. So this is an example of some of the work that we can, the ways that we can depict the metabolic characteristics of the tumor and the mass that we see. And some of the work that we've done very early on through assessing tumor burden. You can see here these CNI maps are really easy to depict where there's active disease, and changes over time potentially is one of the ways that we are trying to also assess. So this is an example of characteristics of this sort of CNI burden within the tumor. And you can see that there are areas that are very, very high CNI. So there's heterogeneity within the metabolic lesion that we see as well. So we've shown that the metabolic lesion is different from the contrast-enhancing lesion. If they were synonymous, then there'd be very little advantage doing a metabolic imaging. But what we've characterized here is that despite the areas of enhancement you see here demonstrated on this scan, the metabolic abnormality is way beyond it, looking at the sort of speaks to the infiltrative nature of this tumor. And so what we've been able to show is that patients inherently with both high choline and high lactate or lipid have a worse prognosis when we look at their outcomes, irrespective of potentially of the size of the tumor itself. In addition, we've been able to show that the quantitative metabolic effects can be important in terms of survival. So we've looked at the sum of the CNI values, as I talked about, combining that with ADC and lipid. So we're able to demonstrate again evidence of these metabolic imaging having a significant impact on the outcome of the patients. We've also done a lot of work on serial changes in the metabolic lesion following treatment. This is an example of survival analysis that we've done with newly diagnosed glioblastomas, looking at pre and post radiotherapy changes. You can sort of see some of the work just visually demonstrating here what we see metabolically changing over time. And working with our radiation oncologists, we can co-register these serial CNI color maps with the RT dosimetry, overlay that so that we can actually characterize the changes relative to where the radiation dose has been administered. And this is some of the work done by Janine Lupo and Steve Bronstein in our team to really understand the changes that we can see of the metabolic lesion following treatment and how that might impact survival. With low-grade glioma patients, determining what happens at the time of progression, whether these tumors remain low-grade or whether they transform to more malignant characteristics. So going from a grade 2 to a 3 or 4 is something that's really important in terms of identifying areas of transformation so that if we're doing surgery, we can identify those areas for biopsy, but similarly also in general for prognosis and treatment management. So what we've done over the last few years through a lot of our PO1 and SPORE grants is to integrate this sort of image tissue acquisition paradigm that we incorporate for all of our preoperative patients, where we acquire ADC maps, of course, it's standard T1 weighted gadolinium scans with FLAIR, perfusion maps, but also now incorporate metabolic imaging into that paradigm. So all of our patients coming for surgery basically undergo these types of imaging, and we're able to do image-guided tissue collection by having this sort of standard operating procedure where we can identify where tissue is being removed, and we can get 2 to 4 samples per patient. And in fact, some of the work done by Joe Costello is really characterizing up to 10 samples within a tumor, so we can look at visual, spatial changes, and that's where a lot of the genomic work is being done to characterize. But this is some of the work that we've done looking at preoperative proton spectroscopic imaging of tumors and correlating this to histopathologic analysis. And so this sort of paradigm of collecting all of this information where we do all of the imaging preoperatively, we have the pathology, genomic characteristics, and are able to now go back and actually correlate all of these changes to clinical outcome is something that we've been able to do across low-grade as well as high-grade glioma. So this is an example of some of the work that I just described in detecting malignant transformation of low-grade glioma. Here you can see their patients, they look very similar in terms of the anatomic imaging with contrast enhancement. But in one case, this is a grade 2 oligo at recurrence with a choline to NA that is fairly low compared to a grade 4 astrocytoma at recurrence with a choline to NA index of 17.4. And you can see some of the work that's been done by Joanna Phillips in our tissue core, looking at the actual correlation of these to the actual histology. So in general, for the non-invasive MRI and spectroscopic imaging biomarkers, this is steady state spectroscopic imaging. We can now characterize tumors based on their biology and what we consider the non-invasive imaging biomarker. And here you can see the differences in terms of the tumor cell properties, the vascular properties, invasion properties, and other in terms of malignant transformation and tumor versus treatment effect. And a lot of this work has been done looking at survival analysis, incorporating all of these various parameters, so this multi-parametric analysis to clinical outcome. So how do we look at metabolic imaging in a way that we can actually leverage understanding the biology of the tumor versus the normal brain? And we know that cancers tend to, in general, have this anaerobic metabolism where pyruvate preferentially gets metabolized to lactate as opposed to this classic bicarbonate that we'd normally see in normal tissue cells. And so this type of understanding of the metabolic imaging is really something that I'm very excited for the last few years to work on actually trying to visualize this in tumors in patients. So hyperpolarization is a way to increase the signal-to-noise ratio of spectroscopic imaging. This is done by over a 10,000-fold difference between what we would normally expect to see using spectroscopic imaging. And I think this is where, understanding how the agents or the probes are metabolized in tumor versus normal tissue is really important. And this is where we would label the C1 pyruvate, for example, and follow what happens to this within metabolism in the tissue to C1 lactate or bicarbonate. And I think this is a great demonstration of how we can incorporate what's called fluxomics. So understanding how metabolites actually go through these pathways that's differential between tumor cells and normal cells. This is beyond, all the other things that we're doing in terms of the genotypes, transcriptomics, proteomics, and metabolomics, but we're looking at actually dynamic changes within the tissue itself. And this is where our research goals have really transformed when we look at hypopolarized C13 metabolic imaging to enhance the sensitivity and specificity of the current MR metabolic imaging to monitor dynamic changes, metabolic probes that we're going to be studying, assess disease activity, and potentially look at this as an early response to therapy, something that I think we're looking at now to try to improve on the outcome of the success of studying drugs, and how do we integrate this into our routine clinical scans. So this is the hypopolarized team. Dr. Dan Vigneron leads the Hypopolarized MR Technology Resource Center. It's a P41 grant from the Cancer Center, from the NIH, that allows us to do all of this work and to deploy this out to other institutions as well. But this is sort of the pathway that it takes. You have to prepare the agent, polarize this, dissolve this, and then allow this to be injected directly into the patient. And then we real-time analyze this looking over a minute. So we capture dynamic information over 1 minute of time as the probe goes into the tissue. So this is some of the work that we've already done through a spore mechanism with Dr. Berger being the PI. This was our project looking at monitoring metabolism in glioblastoma. And this is some of the work that you can see where we're able to evaluate patients using this dynamic effects of giving a pyruvate to patients and looking at the changes within the tumor versus normal brain. We can also, understanding that tumors are now being divided up, as you all know, based on IDH mutation, as well as TERT promoter mutation, et cetera. How do we leverage this information about the biology of these tumors into the metabolism? Well, this is work that we did looking at this particular projects, looking at improving the management of molecular subtypes of glioma, looking at non-invasive and tissue correlates. This is work that includes 4 projects within this and 2 cores, the administrative core and the tissue core. But you can see that what we're trying to do here is really leverage the understanding of the biology of the tumor, the metabolism of the tumor, and try to understand how we can then use multimodality metabolic imaging to monitor subtypes. So we know that IDH mutation produces this oncometabolite 2-hydroxyglutarate. There are multiple trials targeting IDH. The question is, can this new oncometabolite serve as a biomarker of diagnosing gliomas, assessing response, and predicting survival? And this is especially important when we think about the Indigo trial, which was recently published last year, showing this real paradigm shift in the treatment of patients with IDH mutation with this dramatic improvement of progression-free survival in the patients who receive vorasidenib versus the placebo. And so this project is just recently renewed last year. We are incorporating novel hypopolarized C13 imaging as metabolic markers of response in IDH mutant glioma. And this is understanding again that these IDH mutant tumors, we can use C2 pyruvate to really understand how this tumor metabolizes it differently versus normal tissue. So this is some of the work that we've already done looking at C2 pyruvate, but probably what everybody is more interested in is the alpha-ketoglutarate, which is the real upstream target of the IDH mutation. And we now worked with Merck Sigma Isotech to develop a GMP clinical grade alpha-ketoglutarate that's hypopolarized. We've also worked with the NIH and NCI Bethesda to combine resources to evaluate this for human patients. We have volunteer studies being completed, and we will be doing patient studies as part of the SPORE project. We just put in our renewal for our PO1. We hope to get this funded. We'll wait and see. But in this one, I wanted to highlight the fact that we are also now exploring meningioma as a potential way to understand how the various molecular subtypes of meningioma can be leveraged in terms of their metabolism. And so this is work done preclinically by Pavitra Viswanath, where she can see that the various subgroupings have differences in metabolism using C1 pyruvate, but also this probe using alanine. And you can see here very nicely the differences across the three subgroups of glioma that's defined by David Raleigh's team, where we can actually leverage potentially alanine to differentiate as a new probe to differentiate these subtypes. And so the hypothesis is that this advanced pyruvate or hyperpolarized alanine will be able to distinguish molecular defined subgroups. And so we'll be doing this hopefully pending our approval with doing this within our patients as well. So in summary, I just wanted to highlight some of the novel and advanced metabolic imaging techniques that we're doing at UCSF to improve assessment of brain tumor burden, as well as response to treatment. We take in consideration our knowledge of the molecular and cytogenetic characterization of brain tumors and the effects of metabolism to be able to understand what are the best probes and how best to deploy this. This takes a multidisciplinary collaboration with all of our neurosurgeons, pathologists, imaging scientists, radiologists, in order for us to really assess the utility. And we really want to be able to validate and generalize this implementation of novel techniques into clinical care. And so I will end by acknowledging the adult neuro-oncology clinical team, for which a lot of this work and having our patients participate in these work, we would not be successful. So thank you very much. I'm happy to answer any questions.
Phenomenal talk, Suzanne. Thank you so much. I actually have a question. To produce those isotopes, do you have, is that something that will be able to be done at other institutions? Do you have to have a cyclotron or something like that?
So it's not radioactive. It's hypopolarized.
Oh,
so
okay.
There's no radioactivity. It's not like a PET probe that we're developing. Yes, you need a polarizer. But one of the advantages of the P41 that Dr. Dan Vigneron leads is to actually develop a lot of the technology, get this optimized, and then spread this out to other institutions. So I think there's now about 15 to 20 institutions worldwide that are doing this. And this doesn't span just brain tumors. There's cardiac, liver metabolism. A lot of work is being done to non-invasively characterize metabolism across various tissues, but also, of course, in cancer.
Very interesting. I never thought that in neuro-oncology we would end up being experts of the Krebs cycle again, but
brought back my biochemistry training.
That's right. Anybody else have any questions? I think that's exciting, a new era. Okay, if not, I think that it's lunch